become closer together or further apart. But for many of us, they can become closer together and heavier regardless of whether we take hormones or not. Now, a lot of reasons of having bleeding is related to HRT, and it's often related to the not the right balance of hormones. So a lot of people think it's just the estradiol or it's just the progesterone, but it's often the balance of both hormones, and testosterone has a role on the endometrium, the lining of the womb, as well. But there are lots of other reasons why we can get bleeding, and I have done a YouTube live before about bleeding. So I have talked about other causes, and I've done a podcast, for example, about fibroids with a gynecologist, Osami Naji. So it's worth thinking about that, because it's so easy, isn't it, to blame HRT. HRT has had bad press for many years, and there seems so many people trying to dissuade people from taking natural hormones. So we need to make sure as doctors, if someone has bleeding, there's not another cause. So people could have fibroids or polyps, for example. They could have some pathology of the womb or the lining of the womb causing the bleeding. So, they could even have a systemic disorder, a clotting disorder, for example, that's causing their bleeding. So we can't just blame HRT for everything. But this time I'm going to just really focus on what happens, or what does it mean if you have bleeding on HRT. Well, as you know, we usually prescribe estradiol and progesterone together, and if someone's still perimenopausal, we usually start the progesterone for 2 out of 4 weeks, because that helps to regulate the periods a little bit more. And often people with time then have regular bleeding, usually around every month. But of course we're all different, and the first 3 months people can have quite irregular bleeding, and that's partly because they're on hormones, which is something that's just started for that individual, but also their own hormones are sort of starting to maybe work a bit more than they were before, because we often find that when people have exogenous hormones, so hormones that we prescribe, the ovaries start to even work a bit better. But often, as you know, in perimenopause, our hormone levels can really fluctuate. So if you've got fluctuating hormone levels already, and then you're giving hormones, especially when you're having the 2 out of 4 weeks of progesterone, it can cause a bit of havoc in the body, especially initially. So usually we say if people are having bleeding for the first 3 to 6 months of taking hormones, then we can reassure women. Obviously, there are always things that if we're concerned about, or if a woman's concerned, for example, if the bleeding's very heavy, if there are systemic symptoms such as feeling lightheaded or dizzy or any pain, or if the bleeding is persistent and continuous, then we would always bring a person in, examine them, see if they need any further tests at all. But usually bleeding settles with time. Every time the dose or type of hormones are altered or changed, then bleeding can occur. So again, if it occurs within the first 3 months of altering a dose or type of hormone, then obviously we can usually reassure people. And I say usually because I'm just giving very general advice here. So like I say, it's a balance of hormones. Now, we have to be really careful when we interpret the data. I'm very evidence-based, and I'm also very pedantic with my language. So when we think about hormones and HRT, when we're reading literature, we have to make sure we're reading about the same type of hormones and HRT that we prescribe now. And often the case, the articles about any endometrial problems or lining of the womb problems are with the synthetic hormones. So a lot of data looked at using conjugated equine estrogens, which is pregnant horses' urine, and ethinyl estradiol, which is a synthetic form of estrogen. So both of these are not the same as estradiol we produce ourselves and prescribe. So many years ago, they found that there was a small incidence of endometrial cancer, lining of the womb cancer, for women who took estrogen on their own. And then in the 70s, they recommended that we added in progestogens too. And I say progestogen because in the UK and in US, certainly, it was more that it was a synthetic progestogen that was added to the lining of the womb. Now, even when they manufactured HRT many years ago from synthetic hormones, they added in ethinyl estradiol to the progestogen to stop women bleeding, without thinking about the systemic effects that has on the body. And they know that it's very effective of stopping bleeding. But for many of us, it's not just bleeding that's that we need to think about. For women, we need to think about what else we're doing, especially when we're prescribing synthetic hormones. And so Increasingly, we are prescribing the natural body identical hormones. So we don't prescribe synthetic progestogens, we prescribe the natural progesterone, and we prescribe natural estradiol. Now, it does appear from quite a lot of clinical experience and practice from myself and others that the natural progesterone can cause more bleeding, but actually it's a lot safer systemically in the body than synthetic progestogens, which have a small risk of clot, stroke, and possibly cancers as well. So sometimes it's about having the dose altered. If someone's having bleeding, it might be that they have too high or too low dose of estradiol, because sometimes we notice if people don't absorb very well and their levels of estradiol are low, then it doesn't stimulate the endometrium in the same way and they can get bleeding. And it does seem a bit paradoxical, but sometimes we increase the dose and that settles the bleeding. Sometimes people can have intermittent absorption. So, for example, if patches are intermittently not sticking very well, then you can get sort of peaks and troughs of the estradiol in the body just from intermittent absorption, and that can cause some disruption of the lining of the womb and some bleeding. So then we might change to the patch or a different manufacturer of the, change to the gel or a different manufacturer of the patch, and then the bleeding settles. So that's without changing the dose at all, it's just the type. We might change the dose. We might, like I say, increase the dose if the levels are low and we think it's not being absorbed well, or if the dose is raised or higher and the levels are higher, and maybe that's because someone's perimenopausal and still producing their own estradiol, then we might reduce the dose. But the other thing is the dose of the progesterone. Some women don't absorb very well, even if they're on a higher dose of patches. So we wouldn't knee-jerk and increase the dose of progesterone, even though we might prescribe a higher dose of estradiol, because the higher dose is often required just to allow adequate absorption through the skin into the bloodstream and the tissues. And so some women, even on a lower dose of estradiol, might have some bleeding, and then we would increase the progesterone dose for those women with a lower dose of estradiol. Someone with a higher dose of estradiol might be absolutely fine on the standard dose of progesterone. And certainly we've recently published data on this to show that there's no correlation between either the estradiol dose or the progesterone dose in women when it comes to bleeding and thickening of the lining of the womb, which is what we always do, isn't it? In medicine, we individualize care. And this is really important because there's been a lot of confusion, and there are some guidelines in the UK to suggest that women should automatically increase the dose of their progesterone if they're using a higher dose of estradiol. But if you read the guidelines, it hasn't come from any solid evidence at all. And we need to be thinking individually. We know that progesterone can be absorbed in different ways, because usually when we have progesterone, it's orally. So anything that we take orally gets metabolized through our livers, and our livers all work differently. So some people absorb differently to others. So sometimes when people are bleeding, we give progesterone as a suppository, and it might not be practical to give it as a vaginal suppository, so we sometimes give it rectally. And we found increasingly that women who have a higher dose of progesterone, especially rectally or as a suppository, can really, really improve their bleeding short term. Obviously, synthetic progestogens can help, and a Mirena coil can help, but the Mirena coil and progestogens are synthetic. So sometimes we will still, if someone's got a Mirena coil in, give progesterone as well, and I've spoken about this elsewhere as well. Some of the guidelines say that women should just simply stop taking their HRT, and if the bleeding settles and stops, then we know it's the HRT and we can offer alternatives. I find this really quite detrimental, or potentially detrimental, for patients and women, because we know there are many benefits of taking hormones to improve symptoms and future health. So just stopping an evidence-based treatment because of bleeding just seems like we're going back in time, really. And I know myself, if I stop my HRT, I know that I would experience symptoms and it would really impede my ability to work and function. So I'm not sure that being told to stop an evidence-based treatment is good clinical practice. And I've also hear from a lot of women who are told, we're waiting for investigations, my gynecologist has forbidden me to continue my HRT, which again I think is quite strong words to use, but actually often the investigations we do for women who are bleeding on HRT come back as nothing to be too concerned about. In our series, we found that some people did need to go on and have a hysteroscopy and biopsy, but none of our patients had cancer or any atypia, so any abnormal cells at all. Some people have endometrial hyperplasia, which just means thickening of the lining of the womb. And indeed, that can happen whatever age we are, because that's just a natural response to hormones. But that isn't a pathology that needs treatment. So we just have to be really careful what we're doing to women when we just say you can just stop your hormones. So what I'm going to do is just go through some questions, because I have spoken about bleeding before, and I think it's really important actually to try and answer as many questions as possible, because I know it helps the individual, but it can also help everybody as well, because you can share this information and knowledge to really empower people, because that's what a lot of my work is really about. So I'm just going to open up my Instagram first and read the questions and help. And then if any of you who are watching want to answer any questions, then I will open the chat here as well, so I can start to look at the live chat too. So just to go through, someone's on Prostat, which is an injection that blocks hormones working, with tibolone and having bleeding. Well, tibolone is a synthetic combination type of hormone that I don't prescribe at all, and it's certainly not recommended as a treatment. It's not recommended as a treatment in the UK for anybody actually, because it's associated with clot risk, breast cancer risk, stroke risk, and we know that natural hormones are a lot safer. So I would talk to someone about having the natural hormones back. 59-year-old, leftover endometriosis lesions, bled 3 months after estrogen increase. Well, any increase of estrogen can cause bleeding in the short term. This lady hasn't said whether she's on progesterone or testosterone, and certainly women with endometriosis need testosterone and progesterone actually often more than estradiol. So I would often make sure they've got adequate progesterone and testosterone before thinking about estradiol or changing the dose. Bleeding on 200 progesterone vaginally, 150 Everol. Gynae asked me to have a Mirena. Well, sometimes we can give if we give the cyclogest or the progesterone rectally, it can get absorbed better through the mucosa into the bloodstream. So giving it as a suppository is different to giving the low dose of vaginal hormones as a suppository, because those don't get absorbed in the body, but these do. But sometimes we can give more. So sometimes we give 400 or 600. We can give higher doses rectally as well, sometimes just short term to get on top of the bleeding. Also experienced PMS symptoms with my breakthrough bleeds, and that's probably because your own hormones are dropping as well. So if people are experiencing symptoms, then I would think about changing the dose, obviously in guidance with your doctor, but think about certainly, especially the dose of progesterone, but maybe the estradiol and testosterone as well. Having breakthrough bleeds, been on HRT for 2 years. Well, again, breakthrough bleeds don't concern me as much. It's unlikely to have any underlying pathology going on, but actually it's really important to consider about the dosing, and it's those 3 hormones working together. Really, if they're not right, then you can get this bleeding. It's so frustrating. I'm post I think she means menopausal, and love how I'm feeling with HRT but still bleeding. Again, speak to someone about the dosing. And also, if someone's still having bleeding, even though I'm not concerned there's anything more serious going on, I would still often arrange for a scan to make sure there was not a polyp or something else that's causing troublesome bleeding. If I take progesterone for 12 days and get withdrawal bleed, does it mean I have 2 periods? No, not usually. With time, usually your own periods will come in as well. And then we quite quickly change people to once a day progesterone, and then bleeding usually settles completely. Bleeding regular for the last few months. Did cancer test 2 years ago for the same issue? Negative question mark. Well, again, I can't give individualized advice, but it's certainly worth talking about your dosing as well. Progesterone, then spotting, what's happening? Is it counted as a period? So some people can have spotting rather than actual bleeding as such, that's like a period. And again, need to make sure there's nothing else going on. Sometimes I see people that have bleeding from their vagina, and it's more because they've got genitourinary syndrome. So they've got some localized symptoms, and they need a pessary of vaginal hormones that can just help the local tissues. So not all bleeding comes from the womb, of course. If no kids, any evidence that you have period spot for longer? It really varies, because unless you're looking at identical twin studies, you don't know what your pattern and your timing of menopause would be like otherwise. knowing the difference between is it fine, not fine, needs further investigation. Isn't that a great question? And a lot of women are over-investigated. The really important thing is taking a good history. You know, I've seen women who've had full gamut of investigations. When I've taken a history, they've told me that they've been on holiday, they forgot to take their progesterone for a few days, and then they had a period. They've restarted their progesterone and they feel fine and their bleeding settled. So we need to make sure that there isn't anything obvious like that, because we don't need to rush and do investigations for those women. Sometimes people know it feels a bit like a period, so they might have some breast tenderness and bloating, some mood symptoms, and then they have some bleeding. So it's more likely to be related to a hormonal issue than an issue in the womb. So speaking to your doctor, making sure they really talk and ask and quiz and get a good history is really, really important. Some of these questions are the same. Started on medroxyprogesterone in July, worked for a week, but I'm bleeding again. So synthetic hormones can actually cause bleeding. Everyone thinks they're only going to stop, but they can cause bleeding. So we need to be thinking about maybe changing the progesterone as well. Some were on 2 pumps and spotting. She dropped 1 pump, not spotting, but she feels awful. So she's probably not on enough estrogen. So probably increasing the estrogen, maybe thinking about the progesterone dose is really important. Bleeding heavily 2 days after removal of a marina. How is it possible when it's kept the lining thin? Well, there might be another cause for the bleeding, and sometimes it's a reaction to having the marina taken out. So usually it does settle with time. Could testosterone gel cause breakout bleeding? Sometimes it can, because testosterone has an effect on the lining of the womb, but that does usually settle actually. I have to take 2 progesterone tablets at night or I bleed. That's absolutely fine. Some people even need more than that. It's all about how you absorb and individualization of doses, which is so important. So GP not concerned. Should I? Oh no, this is, oh, I can't work it out. So I've got so many here. Should I be considering a continuous regime? Usually it's really varies. So sometimes if people have been on the cyclical regime, so 2 out of 4 weeks for a few months, we might change to continuous. And then if they got a lot of breakthrough bleeding, especially if we think they're still perimenopausal, then I often suggest to go back to the 2 out of 4 weeks, and then the bleeding becomes more sort of regular and predictable, because there's nothing worse than having unpredictable bleeding. So you know, you can be on the cyclical type of HRT for longer if you're still going to have some irregular bleeding. So I'm just going to go over to the questions here so I can answer them. What can you do when your Vagifem won't stay put due to bleeding? So it's difficult. I mean, getting on top of the bleeding is the most useful thing. Sometimes people use an S-ring, which is a silicone ring, which can be used for 12 weeks at a time, and that stays in a lot better, even if you're having bleeding. So looking at alternatives as well. I have marina, my sleep isn't great. I can't tolerate eutrodestin orally. So you can use a progesterone as a pessary. It doesn't have the same metabolic effects as oral progesterone, because it doesn't get metabolized and stimulate the GABA receptors, but some people do find quite calm with it, and they do feel that they can sleep better as well. What should be the balance? Well, the balance, it's all different. So it's not just looking at the doses, it's not just looking at the levels. And in fact, we don't do progesterone levels because they vary so much. So it's more making sure that you see someone who's really experienced with hormones. And like I say, some people need their estradiol increasing, some people reducing, some people needing the dose of progesterone increasing or reducing, and some people need different preparations. So it can't be really simplistic as, you know, a sort of flow diagram. Is this lady bleeding? Yes, no. Does it, you know, should we increase the dose, reduce the dose? This knee-jerk response in medicine, which is just guideline driven, is not individualizing care, and it can cause a lot of confusion for doctors, but also for women as well. So we have to be taking really careful histories and just working out what the absorption of hormones is like and how they are balancing together, and if the woman's perimenopausal or menopausal, that can make quite a difference as well. My mum, sister, niece, and I always had heavy bleeding. We've had factor 5 deficiency. Is there a link? Then factor 12 deficiency. Yes, there might be. So there are some people do have clotting deficiencies, and also there are other things we can do for bleeding. Something like tranexamic acid can be very useful to reduce bleeding, and we use it a lot in younger people who have bleeding, but we can use it in other older people as well. If someone is having bleeding, just to add, I always would do a ferritin level. And a lot of ferritin, the labs are set up as normal, and the bottom figure is really quite low. I think it's 10 in many labs over in the UK, but ideally you want it to be above 75. So if someone's got a ferritin of 20 or 30, that is low, despite the laboratories saying normal. So having an iron replacement can really make a positive difference to people as well. Before I had HRT, I had a period every 4 months. After HRT, I have my period every month. I'm 55. Well, it depends on how you're taking the HRT. Ideally, you shouldn't have periods. I mean, that is the nicest thing of taking HRT going forwards, and with time, it should settle. I have a rectocele. Should I be taking my progesterone via my rectum? It doesn't really make any difference. I mean, if you can use it rectally, fine. But if you've got a rectocele, sometimes making sure you're on vaginal hormones like progesterone, even though they're used vaginally, they can still help the rectal tissues, and that can often make quite a difference. But like I say, you can put the progesterone in your vagina or your rectum. It's a personal choice, really. First week off cycling progesterone, my skin feels itchy like I've got fleas. Is this normal? It can be, and some people, do you know what, just feel better when they take progesterone all the time, and that's absolutely fine to do that. The only reason we cycle it really is for the periods, but we don't always have to have periods, so you can continue taking it. There's no sort of absolute with any of this, really. My doctor says she cannot prescribe cyclodextrin told me to insert my oral gel tablet, but it's off license. Yeah, so it's off license, isn't it? Using it vaginally. Cyclodest is off license as well, but I'm not sure why there's a resistance for one rather than another, really. It might be worth maybe talking to another doctor and see if they can prescribe it for you. I'm on 3 pumps of gel, merino coil, started testosterone, improved sex, muscle pain, brain fog, but started abdominal swelling, change in bowel movements. GP says I have IBS. Should I restart testosterone? So our gut microbiome can be really affected by all 3 hormones, estrogen, progesterone, testosterone. And when our gut microbiome changes, it can cause all sorts of sort of bloating, bowel symptoms, but often they're quite temporary. Obviously, looking at your diet's really important, but you need to give it a few months really to settle down and change. So sometimes people find that they feel worse and then improve. It's a bit like eating lentils for the first time. Your bowels can be quite upset with it. And then really can improve. But looking after our gut microbiome is so important. Been on this for 6 months, have vaginal estrogen pessary, bleeding has changed, become painful. So if you've a vaginal estrogen pessary shouldn't cause any difference to any bleeding at all. It might be a coincidence, but sometimes what happens is if people have started their HRT, for example, when they're perimenopausal, then their own hormones fluctuate and reduce. The hormones don't always reduce at the same time as the other hormones, so you might find that your progesterone is reducing more than your estradiol. So sometimes people might need a top up of progesterone and not estradiol, or the other way around as well. So even if we think we're menopausal, we're still producing hormones from our other tissues, so that it's useful talking to someone who really does understand. Let me just look at some other questions here. Thank you for all your questions. It's great. Can testosterone or DHEA increase estradiol levels and that can cause bleeding? Theoretically, but it's never been shown. I know testosterone aromatases to estradiol, but not a huge amount, to be honest. Testosterone does have an effect on the lining of the womb as well, so sometimes people can have it intermittently as well. What's the least levels of progesterone and estrogen we should be to protect ourselves? Well, I don't do progesterone levels. Estradiol levels just a guide. In the UK, we sort of aim between 250 and 1,000. Testosterone levels, again, we do free androgen index and testosterone and have a look. But again, it's just a guide. So I would never say sort of an absolute, really, because, like I say, the way we respond to hormones is all really, really different as well. Can we get cyclodextrin in the UK? Yes, it's available. I mean, it's used a lot for fertility treatments, and it's really frustrating when they say they can't prescribe it. I have very few hormones due to chemotherapy in 2020, full of joint pains, told I can't have HRT by my oncology team. I'm totally fed up with this part of menopause. I'm really, really sorry to read that. Chemotherapy will often induce the menopause. Sometimes it's temporary, sometimes it's permanent, depending on your age and type of chemo, of course, and everything else. Depends what type of cancer you've had. I don't think anyone can say you absolutely can't ever have HRT. There are always benefits from HRT. And there might be risks for some women who've had an estrogen receptor positive breast cancer, but we don't know because the good studies haven't been done. Estrogen is a blanket term for different types of estrogen as well, and it's thought that estradiol is very beneficial because it's so anti-inflammatory as well. So even the estrogen blocking drugs like aromatase inhibitors will block all types of estrogen, not just estradiol. So I think the short answer is we'll never know, but actually a lot of women I see really suffer having had chemo and have had a cancer. But it's not just about estrogen, so sometimes we give testosterone on its own for women who are suffering, and that can really improve their symptoms. Vaginal hormones can be safely given, and progesterone is another hormone as well. So don't suffer alone, try and see someone who understands. And often it's an individual choice. It's discussing the potential risks with potential benefits, and individual women can decide. And then often when people start taking HRT or testosterone or whichever combination of hormones, and if they start to feel better, they might decide, well, I want to have a small increased risk because I want the benefits as well. It's a bit like if people drink alcohol. They know there are small risks with alcohol, but they enjoy the benefits. So it's very, very individualised. And I feel very sad when women are just told, no, you can't have HRT, when we haven't got good quality studies showing that there are harms. And we do know there are harms of other medication as well, like antidepressants are associated with osteoporosis and dementia, but people don't seem to have any qualms prescribing those. So we just need to put things into consideration and individualised care, really. Let's have a look. What do you think of estrogen, 14 days off and 14 days off, in order for letting the hormones interact and creating and shredding cells? No, our hormones respond to estradiol. They have receptors on them and they're constantly using the estradiol. It's the lining of the womb that changes, but the rest of us really, I don't think that's unless people feel great for doing that, I wouldn't do it, because you're going to have 2 weeks of a pro-inflammatory state and 2 weeks of an anti-inflammatory state. So it doesn't sort of make sense in my sort of maybe a bit too simplistic logical mind. Why do some women get extremely itchy and sore by the vagina from HRT? Well, you can get itchiness anywhere in the body, and that's just often due to the way that the nerves endings are sort of on fire, if you like, because they're not being stimulated in the same way by the estrogen and testosterone. And then the hormones, all three hormones, progesterone, estrogen, testosterone, can have effects on the vaginal and vulva and the surrounding tissues. All of those tissues respond to hormones. And so some of the symptoms, as well as having drying and soreness, can become a lot of itchiness. Sometimes when people start hormones, the cells sort of regenerate again and work differently, and people can get some short-term symptoms. But it might be that you need vaginal hormones as well. So it's really important. A lot of people think it's only due to estrogen, but obviously often progesterone and testosterone can have an effect too. No, I've done that one already. I've got a Marina, just started an estrogen spray. This month I've been bleeding, more brown than red. Is this normal? Well, because you've just changed your hormones, it can be related to that. Often in my experience, the spray gets intermittently absorbed. So therefore, anything that's intermittently absorbed can sort of destabilize the lining of the womb and cause more bleeding. Oh, sorry, it's jumping around. I hate it when it does this. The only thing I took my brain from away is testosterone. Good. I'm on my third change of HRT, light bleeding and spotting on each change. How long do they give it? Usually 3 to 6 months. Honestly, it depends. If I have someone in front of me who has very heavy, persistent bleeding, then I will investigate them a lot quicker than if someone says, oh, I just get a bit of spotting every 3 or 4 weeks and it's just for a few days and I feel absolutely fine. So the clinical context is really, really important. You can supplement with iron and vitamin C. Yeah, great advice. Thank you. I changed gel and patch in a week, developed pins and needles, numbness, the fingers and upper lip. This resolved with return to gel. It's often due to the intermittent absorption as well. 14 days off on with the progesterone, not the estradiol. No, even then I wouldn't. I was talking to Felicia Gersh the other night, who I know recommends cycling for some people, but 2 weeks is quite a long time. And we have a lot of experience prescribing progesterone with often transformational effects. So I'd be nervous of reducing the progesterone for so long in women that have benefits. Some women find like a 3 or 4 day reset, they feel really good. But again, it's about individual. 200 milligrams cyclical utrogestan. Bleedings usually come right before or after pausing utrogestan. Should I continue or should I adjust? Depends on how you feel. You know, some women really like to have periods and other people don't. And so again, it's just working with your healthcare provider, working out what's right for you. But sometimes it can be frustrating because you think you've got things just right and then things change and our metabolism changes. Our hormone requirements can change if we're under any stress, either physical stress, like from exercising, or mental stress, or depending on what we eat. There's so many different variables, and we're never going to get the perfect amount or type of hormones because we are all so different. But making sure that we work out what feels right for us and that is sensible as well. You know, you have to remember that I'm talking about natural hormones here. The modern natural hormones we prescribe are just replicas of our own hormones. Very, very different to synthetic hormones of the past that have all been associated with various risks. So I hope that's reassured you. I think one more question has popped up. Is estrone vaginal cream the same as estradiol? No, it's not, because there are different. We've got estradiol, estrone, estradiol. Vaginally, you can get estradiol and estradiol, but you can also get DHEA, which is prasterone, which I've spoken about in another Instagram live. So it's often more beneficial because it contains DHEA, which converts to testosterone and estradiol. So it's all about choice, and it's all about what works for you. Might not work for your neighbour or your friend or your colleague, but making sure if you're feeling good on the right balance and type of hormones for you, then that's the most important thing. So there's been a lot of information, I understand that, but I hope it's been really useful, and I think it will help lots of other people as well. Often, just to add, that we often know our bodies more than our doctors and our gynecologist. So be intuitive as well, and obviously take advice. But if someone's telling you something that doesn't feel right, for example, just stop your hormones, and you don't feel that's right, then speak to another doctor. Get other independent advice, because it's really important that you are not made to feel sort of inadequate, or that a decision is be made about you that isn't quite right. So have a good week, and thank you so much for all your support. And for those of you in the UK, I hope you're going to come and see me either in Glasgow, London or Birmingham in October. I've got 3 theatre dates. It's on my Instagram, you can see, and it will take you to the booking. And then there'll be loads of questions there. It's a really good opportunity to ask as many questions as possible, so you can really challenge me and challenge my brain. So thanks for your support, and I hope you have a great week.